So I want to apologize in advance. This is like kind of a crazy talk. It's like 4 or 5 hours worth of material that I'm cramming into 45 minutes. And it's not going to make any sense to anybody, and I'm just letting you know. But there's a reason I'm doing this, which is that there are certain sort of strands of thinking that are going through my head right now that I'm just trying to make some sense of. And so this is really a therapy session for me. And I just want to go through some of these strands. So first, we've got this grant with Lucile Packard to try to use some neat techniques to try to develop a national consensus on population health and health outcomes for children with medical complexity. The idea being that if we can kind of define this group as a population, then maybe we can sort of come to some consensus about down the road things like quality measures and things for groups of kids that you wouldn't think would be connected because they all have various rare disorders and are also unique. But that has made me think a lot and very deeply about population health and what it means. And then the second strand is just the work that I've done with the Pediatric Policy Council, where we've just been involved, on a daily basis on child health policy issues and trying to figure out sort of what is it that we want to be advocating for in DC with legislators and with agencies on behalf of kids. And then finally, sort of the work on the task force on child poverty. And primarily, the last half of this talk is actually going to be a sneak preview. You guys are actually going to be the first people to get a sense of the academic pediatric supplement issue that we're putting together that'll hopefully be coming out in April. And it's really going to be kind of a sort of a state-of-the-art summary of sort of where we're at in terms of our thinking on child poverty in the US. So how many of you guys know what the triple aim is? Yeah, a decent amount. If you don't know, you should, because the triple aim is the core principle that underlies the Affordable Care Act. It was developed by the IHI, the Institute for Healthcare Improvement, which was led at the time by Don Berwick, who then became the head of Centers for Medicare and Medicaid Services and was one of the main implementers, really, of the ACA initially. The three aims are improving patient experience of care, reducing per capita cost of healthcare, and improving the health of populations. Now, the first one, basically, it's kind of like quality satisfaction, and people were okay with that. The second one was cost. Okay, quality, cost, we get it, right? The third one gave people some pause. What exactly does this mean? This was, I think, to a lot of people, a fairly unusual thing to include as one of your three main aims. But what it means is actually kind of profound, which is that it's no longer enough to think about one patient at a time, or even all patients in one institution or system. I mean, what was it? Healing humankind one patient at a time was always such a, it was ridiculous. It was. I mean, I don't know who wrote that motto for UCLA, but it never made any sense. But it's more than that, right? It's that we can't just think about the patients that walk in our door. Now we have to think about the communities in which they live. And we have to think about the people that we never see and the people who are not our patients. Now, this seems patently unfair, right? How is it that we are suddenly responsible for entire populations of people that we're never going to see? And really, the response to that is fairly direct, which is that, we spend 17% of GDP on healthcare. And if you look at 10 of the top 11 highest paying job categories in the United States are physicians. Just so you know, corporate CEOs are around like number 5 or number 6. They're the one that doesn't fit. Number 1 is anesthesiology, and number 11, of course, is pediatrics. But the idea basically being that, if you think this is unfair, well, tough luck, right? Figure it out. So the response to this is, the possible responses to this are really come in two flavors. First, you can do what UCLA health system decided to do, which is just to go big. It's all about lives, capturing lives, 1 million lives, 2 million lives. If you become big enough, then you will actually absorb as your patients a population. And that's one way to do it. Another possibility, though, is to figure out how to fundamentally change what healthcare means. To make healthcare broad enough so that the activities that you do actually will have an effect beyond just the patients that walk in your door. But it's a little more basic than that. I think that fundamentally we're still a little bit confused because what exactly is population health? And the crazy thing is that nobody knows. I mean, it's amazing, actually, that nobody actually has any real idea what population health is. If there is a consensus definition at all, it's this. And it's not a consensus definition, but it's the one that's sort of most commonly thrown out there, which is that population health is the health outcomes of a group of individuals, including the distribution of such outcomes within the group. Now, this is a very narrow, comforting definition. I mean, it's the reason, I think the reason why it's a popular definition is because it's easy on us. Basically, it doesn't make any demands. It just says you take care of individuals. You know, people walk in your door. You take care of them, and then you average them out, and that's population health. And that's how you can sort of define it and measure it and work on it. And plus, there's this emphasis on disparities. So this idea that, you know, you're going to have this distribution of outcomes, and then the folks at the bottom, right? You just give them a little extra attention, and you're done. That is popular, it's plausible, but I think it's pretty thin gruel for us. Because I think that population means something more. When you talk about a population, you're not just talking about some random individuals who walk in through your door and are connected to each other in no other significant way. I think you're talking about groups of people that are somehow fundamentally bound together by complex social ties. When you are in a population, that also means you are not part of other populations. There's this exclusiveness about it. And what are these ties? These ties are social systems. People are bound together by social systems. And these social systems include families. They include schools, workplaces, neighborhoods. That, I think, is a truer definition of population than the one that we would like to believe. But even more basic, you have population health. You have population and you have health. What is health? Nobody knows. We're all dedicating our lives to this pursuit of health, and we have no freaking clue what it is. It's amazing, right? The WHO back in 1948 tried to put out this definition, which is, and this is by far sort of the most commonly used one. You'll see this everywhere. You all probably know this. You probably learned it in medical school. A state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. Now, this is somewhat useful, okay? So it's established domains. There's the physical domain, the mental domain, and the social domain. That's great. Plus, it really brought to the forefront this idea of well-being. It's not just about absence of disease. But if you look at it as a whole, it's useless. How are you going to take this definition and operationalize it in any concrete way? So it has been recognized as a weak definition. And back in the 80s, the Ottawa Charter for Health Promotion tried to do better. So they defined it as a resource for everyday life, not the objective of living. Health is a positive concept emphasizing social and personal resources as well as physical capacities. This is better. It's better because health is not an end, but a means to an end. Right? Not the objective of living. But we use health to do stuff. But what is the end? So, in 2009, in the Netherlands, they had this giant international conference where they brought together all these people, and they tried to come up together with a consensus definition. This is, and what happened is, I think what happens every time you get a bunch of people together in Europe to come up with a consensus, and you get complete gibberish. You get an inner resource, a capacity, an ability, a potentiality to cope with or adapt to internal and external challenges to perform relative to potential aspirations and values, to achieve individual fulfillment, to live, function, participate in a social environment, to reach a high level of well-being, even without nutritional abundance or physical comfort. They wrote this. I mean, I tip my hat to them. But I think underneath all of this, there really is a meaning that comes through, which is that perhaps achieving optimal health, and Liz is laughing because we're having this argument about whether we should use the word optimal, but perhaps achieving optimal health means, first, maximizing one's individual potential, and then, second, participating in society to the best of one's ability. If you can do those two things, you have achieved health. Maximizing your individual potential and then participating in society, finding your gift and giving it away. And I think this really leads us to a better, more concrete definition of health. I apologize for the wording, because the wording is difficult. But at least it's short. I think we can maybe consider defining health as expected future net societal value added. Okay. This makes no sense to anybody, I realize. It doesn't even make any sense to me, but we're going to break it down. Expected future, which means that your present health, the health that each one of you has right now sitting in your chairs at this moment, is actually a measure of the future potential that you have through the remainder of your life course. You walk into a room, you see a kid, and you look at that kid and you think, oh my God, this kid is sick. This kid is not healthy. What are you actually saying? You're actually saying that you are prognosticating about this kid. You are thinking about this kid's trajectory, or either the trajectory that the kid did have or the trajectory that the kid is supposed to have, and you're saying that trajectory is threatened. That is how you define whether this kid is healthy or not. So let me ask you. You walk into a room and you see a kid who has never been sick a day in his life, but who's failing out of school. Are they healthy? Huh. Net. What you give is diminished by what you take. We have to take this into consideration, right? We give to society, and I'm not just talking about economically give to society, not economic production. We're not really talking about that. We're talking about other forms of value. We're talking about joy. We're talking about being part of the social fabric. And societal value added, measured as probabilistic benefit to society, to others. And not to yourself, but to others. We find our gift, and then we give it away. I think this comes closer to capturing what we instinctively mean when we talk about health. I don't know, you may disagree, but this is where I'm going, and I'm talking, so. So I think population health then is this. If you put together those words, population and health together, what you're really talking about is the ability of social systems that bind and serve a group of people to increase the expected future net societal value added by that group's individual members and by the group as a whole. Okay. I think on the one hand, I'm hoping that that will be intuitive to people. On the other hand, I would understand if it sounds very different, probably, than what most people hear when they talk about population health. So we're talking about social systems. So then we have to ask, what do social systems do? And the answer is that they create health for populations. That is what they are designed to do, for the most part. And here is a fun curve, or a set of curves. It's actually chimpanzees versus humans, okay? And you can see that there's 4 lines. There are 2 light lines, one solid and one dotted, and there's 2 dark lines, one solid and one dotted. The dotted lines are survival curves. So basically it tells you sort of, and the left-hand side is survival, and it tells you what proportion of the population is still alive at what age, okay? And the solid lines are production. Okay, in this case, food production. And we're not just talking about chimpanzees, we're talking about chimpanzees and human foragers. So it's not a particularly advanced or developed society, right? But still, you see differences. So what happens in a chimpanzee's typical life? So for the first 5 years or so, basically they just consume. They consume and grow, consume and grow. Somebody feeds them. They don't contribute anything, right? But then they become adults and they start producing on their own. And that production continues, and around age 35 or so, I didn't realize chimpanzees can live so long, but at age 35 or so, it all starts to sort of fade away, and they hit zero, and they starve to death, and they die. Okay? And that's a chimpanzee's life. Human foragers, even sophisticated or developed societies. So actually, I shouldn't even say that. But human foragers are different. What you see is that their children consume so much more, right? That dives down, okay? But it has dividends. What you invest in these children ends up creating a much higher production curve later on in life. A production curve that is not only higher at the peak, but that extends further out, right? And in fact, it's so much production that you end up with a net positive return. You have excess production. The area under that production curve is greater than the area above that investment curve, right? And it doesn't end there, because what can we do with that excess production? And you see at the far right, what you see is that once you get past age 65 or so, it goes negative again. But it goes negative, which means they're still alive, which means they don't hit zero, starve to death, and die. What we do as societies is we build up resources through investment, and then we spend those resources to do things like extend life, to take care of the elderly, to take care of the sick. So we see that social systems, and by the way, if you looked at curves for sort of more advanced civilizations and things, what you'll see is that these investment curves get ever deeper and ever deeper. And if any of you send your kids to private school, it goes, basically below the slides. But the returns are much higher and extend much longer. And this is actually how societies grow and develop, and this is what distinguishes us from the chimps. So social systems serve two purposes. The first, then, is to invest in productivity. I call these productive systems. And these are deep investments in children with supportive investments for parents, for those who care for children, also for things like schools, et cetera. And then maintenance investments in sort of all productive age adults, because everyone's in this together. And then that excess production is then reinvested in children, caregivers, and productive age adults. But that's not all we do, because if all we did was invest, then we would be a miserable society. Miserable. We take excess production, and yes, we need to reinvest some of it. But if we're a society that wants to feel good about itself, then we're also going to spend on moral obligations and quality of life. I call these moral systems. Large expenditures on the elderly and the safety net, supportive expenditures on quality of life, where your excess production is not directly reinvested. It might end up being reinvested and might end up improving productivity, but that's not the main purpose of it. So moral systems are aspirational. What we want as societies is to get to the point where our excess production allows us to be moral. That's what we desperately crave as a society. But it's also secondary, because we can't do it without the production to begin with. Or if we do it without the production, then we're just being irresponsible. So what does the US healthcare system do? Take a look at the right-hand column. We spend a lot on the elderly. And we spend a lot on the sick. And I think it becomes clear then, sort of structurally, what we as a system are designed to do. We are a moral system, primarily a moral system. We spend excess societal production on the elderly, we serve as a safety net for the sick, and we contribute generally to quality of life. That's not a bad thing. That's a great thing. But everybody right now is just complaining that healthcare doesn't really do much. We can't find much evidence of anything that to show that healthcare increases societal productivity. And you know what? It doesn't. It doesn't. It's not what it was built to do. Any improvements in productivity through healthcare are just mainly incidental. There are probably some exceptions. In fact, there are some exceptions. But for the most part, that's what it is. But we're pediatricians, right? Have you guys felt, or you guys always felt that somehow we're not really part of the healthcare system? We're separated from it somehow. We're second-class citizens, and obviously we don't get as much money and all these things, but there's more to it than that. And I think that what it comes from, to a certain degree, is that first of all, most children are neither old nor sick. There's Peter Pan and there's Willy Wonka, but we don't really talk about them because they're kind of creepy, right? Really, maybe improving productivity may actually be the core purpose of what we do, which sets us outside of the healthcare system to a certain degree. So if we take that frame and we think then, what are the key childhood determinants of adult productivity? Adult productivity, which could or should perhaps be the main goal of pediatrics. The list is really short. It includes fetal nutrition, growth, and stress, toxic stress and resilience. By the way, have you guys all heard of things like Barker hypothesis and ACEs? And I think if you haven't, you should learn about them. We don't have enough time, so I'm just going to blow right through. But these are really sort of key things to know about. Child development and education. You could separate them, but I like to think of them to a certain degree as a continuum. Social inclusion, exclusion, and isolation. These are really, really key. This includes things like, things as prosaic as bullying, but also things like racism and incarceration and family separation and foster care and all of these things. Physical and mental health and care. It does matter. It really does. And income, wealth, and inequality. And I have bolded, italicized, and underlined that because to a large degree, all 5 of those previous bullets are encompassed in some way in this issue. Just a couple of quick things. I'm going to talk about education and income. This is a sort of remaining life expectancy. So if you hit age 25, how much longer can you expect to live? On the left-hand side are orange is women, blue is men. On the left-hand side, it's going to be less than high school graduates. On the right-hand side, it's going to be a graduate degree. So it turns out that a college graduate is expected to live up to about age 87 if you're a woman and age 82 if you're a man. But for a less than high school graduate, it's age 75 if you're a woman and age 69 if you're a man. So you're really talking about a 12 to 13 year difference based on education. That's astounding. I think it would be difficult to find any other single factor that has a stronger association with life expectancy than education does. I'm not saying it's entirely causal, but it's a huge association. Income and health. Very similar picture, slightly less dramatic. 7-year difference between middle class and above versus officially poor. But here's where the damage really starts to accrue, right? It's when you combine education with income. And this, I showed this to you like a couple of years ago, and I'm going to repeat the slide. I'm going to repeat this same joke. I apologize. But you just look at the left-hand side, and you look at these are low-income kids, and blue is sort of kids who perform poorly on testing, and pink is kids who perform well on testing. And you look at that and you say, wow, the high-performing kids who are low income, they have a 29% chance of completing college. That's great, right? It is great until you look at the right-hand side and you realize that the chance of a low-performing, high-income child of completing college is actually higher than the chance of a high-performing, low-income child completing college. And you think back to your college days, and you look around, and remember when you were in college and you looked around and you said, my God, everyone around me, they're dumb as rocks, right? And you know what? You were right. They were dumb as rocks. They were just rich. That is amazing. And then it gets worse, because then looking even just at parents who are employed full-time, I mean, this is the cream of the crop, right? Your parents are employed full-time. If you came out with less than a high school education, there's a 73% chance that your child is going to grow up poor, right? And if your child grows up poor, then there's only a 29% chance that they're going to end up completing college. And if they don't get educated, then they're going to end up with a lesser degree, and they're going to have poor kids. And it just goes around and around and around, and we call this intergenerational cycles of poverty. Okay? Intergenerational cycles of poverty are compounded by one inconvenient fact, which is that poor people, by and large, cannot move, and rich people can. And rich people can move to rich neighborhoods and gated communities and do all kinds of zoning and all kinds of ordinances that exclude poor people from ever getting into their neighborhoods, and you end up with this. All right. So back in 1970, the vast majority of people in the United States lived in mixed income neighborhoods or middle class neighborhoods. That would be the light blue and the light pink, right? Over the next 40 years, what you see is this amazing contraction, not of people so much, but of neighborhoods. What you see is that the number of poor neighborhoods where you've concentrated poverty is going up and up and up, but also the number of rich neighborhoods where you've concentrated wealth is also going up and up and up. And you have this separation. Now, this matters because educational, economic, and family systems, the systems that we're talking about, define and are defined by neighborhoods. It is about where you live. And these neighborhoods are becoming more homogeneous and extreme over time. It's not going away. So even if, on the whole, you're looking at, say, poverty numbers, and poverty numbers don't really appear to have changed that much over time on an individual level, poverty is still a growing problem. It's getting worse and worse because what you're seeing this greater concentration of poverty within these neighborhoods. Which brings us to the poverty supplement. Now, this was funded by RWJ and with an expected publication in April. And the goal was basically to raise pediatric awareness of child poverty and kind of put out a call to action. The authors are from all over the place. We really wanted this to be a comprehensive look at child poverty, and these are the sort of the big sections of it. I'm going to take you through just a quick summary, a sort of a pulling together a thread of not all of the articles, but a few of the articles, just to tell a bit of a story. These are the specific articles that we're discussing here, and I'm really happy about the depth and breadth of the articles that we're going to be putting out. First, poverty is not what you think it is. Okay, there are actually 3 official income poverty measures. The one that everybody knows, the one that everybody talks about is before tax income, which that poverty is defined as before tax income less than 3 times the cost of a minimum diet. I mean, it's totally arbitrary. And the person who invented this official poverty measure completely admitted that years and years ago and never wanted this to be used in any kind of official way. But you know, at some point, some bureaucratic body said, you know, this is good, let's go with it. So that's the poverty measure that we use. Now, there's also a relative poverty measure, which is mainly just used for international comparisons. And then there's this thing that was first put out in 2009 very recently, called the supplemental poverty measure. And this is a much more comprehensive look, which takes a look at your income after benefits, taxes, and other expenses, and compares it against an entire basket of expenditures that are more than just minimum diet, and really talking about sort of food, clothing, shelters, utilities, incidentals. It is, at this moment, by far the best poverty measure we have. And I'm going to be relying heavily on this. There's a newer research measure, which we're going to talk about, called anchored supplemental poverty measure, which is just a way to basically allow us to use supplemental poverty, but to take that measure and extend it back historically so we can look at trends over long periods of time. And assets matter too. Okay? It's not just about income poverty, it's about assets. And Adam Shikadance, who's sitting right there, has done a study looking at the panel study of income dynamics, which really is amazing. It shows that the longitudinal effects of asset poverty, that is, not having enough savings, not having wealth, not accumulating things, that the effects on health, on child health longitudinally, are just as bad as the effects of not having enough income. The two are different concepts, but they're related, but they're very different. And we can't just focus on income. We also have to focus on how much wealth somebody has, not just how much they're getting. But what does the supplemental poverty measure tell us? It tells us that the official poverty rate measure in 2014 said we have 21.5% of our kids in poverty, but the SPM tells us, no, it's actually only 16.7%. I mean, still, it's a lot of kids. But there are things that we do that actually help. Number one on that list, by far, are refundable tax credits. I mean, this basically points you a roadmap for policy. This tells you, what can we do to reduce poverty, child poverty in America? And it tells you kind of exactly, this is what we're doing and this is what works. And this is what we're not doing at the bottom, and this is what hurts. FICA taxes. Isn't it interesting? Those are Social Security and Medicare taxes. Isn't it interesting that we're using those taxes to spend on moral obligations and expenditures, and by doing so, we are actually driving children into poverty? Work expenses, right? We are supposed to be making investments in children and their parents so that they can take care of their children, right? Medical out-of-pocket expenditures. See, healthcare is important. It's just that it's not healthcare for kids that drives families into poverty. It's healthcare for their parents. This was one of the main objectives of the Affordable Care Act, was actually to help kids by giving their parents health insurance and reduce their out-of-pocket expenses. So let's look at official income poverty trends. And what you see is a fairly simple story, which is that it really sucked to live in the Eisenhower and Kennedy era. Okay? It was a horrible life, basically. And what happened then was Lyndon Johnson came around and started the war on poverty and the Great Society. And from that, you see, especially looking at people aged 65 and older, you see that their poverty rate drops all the way down to 9.5%. And they went from being by far the worst to being by far the best. Children, on the other hand, just kind of hopped around that 20% mark. They were initially helped with the war on poverty, and then they just kind of, stuck around. And what you can also see is that there is a sensitivity to recessions. So those bars are recessions. And you can look back and you can see there was the Reagan recession, Carter and Reagan recession, which really put child poverty up. And then things got a little bit better. And then you had the first Bush recession. And then things went back up. And then things got a little bit better, in fact, markedly better in the Clinton era. And then there was the Clinton recession, which is really the Clinton recession because it started in the tail end of his presidency. And that actually didn't seem to, it was mild enough that it didn't seem to really do a whole lot. And then there was the Great Recession that we just went through. And we're right back up, right? But that's the official poverty measure. And different measures tell different stories. Official poverty measure is the official poverty measure is the dark purple. Supplemental poverty measure is the mid purple. And you can see that if you use the supplemental poverty measure, it turns out that kids are a little bit better than we thought they were. And it turns out that the elderly are quite a bit worse than we thought they were. And actually, there's a fairly even distribution of poverty in the United States across the age spectrum. It's all way too high. But that huge disparity that we for years and years have thought was there is not quite as bad as we thought it was. Moreover, the benefits that we've been providing for children and families have actually gotten better. They've improved over time. Red is the supplemental poverty, and blue is the official poverty. And what you can see is that back in 1968, children's real level of poverty was way higher, was twice as high as their official level of poverty. But that gap narrows and narrows and narrows over time, and right in the middle of the Bush presidency, it crossed. It crossed. What's more is that you see with the supplemental poverty measure, you also see these big upticks in recessions initially, but look what happened in the Great Recession. Nothing. Nothing. This means that the benefits that we're currently providing are doing a lot. Not only are they just bringing down overall rates of child poverty, but they're actually protecting children from poverty in times of stress, like the Great Recession. That's kind of cool, actually. And protective benefits increase health. The ones that are best studied, earned income tax credit, SNAP, which is formerly called food stamps, right? Medicaid and CHIP. It's kind of incontrovertible, actually. I mean, the evidence is so strong that these benefits provide both short-term and especially long-term health benefits across an entire range of outcomes. Okay? So this matters. It's a big deal. It's also, and by the way, all of these are threatened. I don't know if you guys have been following the news, but President Obama currently is trying to work out a negotiation with the Republicans to accept some really kind of odious corporate tax exemptions in exchange for making the earned income tax credit a permanent benefit as part of the tax code, which would be kind of amazing, actually. It would drastically increase the deficit, but we can get to that later. So the other thing to think about is that, okay, we know that these benefits work. They protect kids. Education prevents. This is amazing. We talk about what is the education dividend. This is the education dividend. If you have less than a high school degree, if your parents have less than a high school degree, you have greater than a 50% chance of growing up poor. If your parents have a high school degree, it drops into the 20s. If your parents, there's a white line here that you can't see. If your parents had some college, like an associate degree, it drops down to the teens. If your parents are college graduates or greater, it drops down into the single digits. Okay, this is huge, huge. And what you're also seeing is that high school graduation is not quite as valuable as it used to be, whereas advanced degrees are more valuable than they used to be. So there's all these things going on. And I wanted to just quickly tell you a success story, which is the UK experience. All right. Basically, back in 1999, Tony Blair just said, we're going to end poverty, end childhood poverty. And they set a target of cutting child poverty in half in 10 years. They decided to invest, they called it 1% for the kids, and they decided to invest 1% of their GDP in children and families. Now, in the US, 1% of GDP is $177 billion. It sounds like a lot of money, except for the fact that it's about roughly the same price tag as the entire Affordable Care Act. And except for the fact that $177 billion is about 6% of our healthcare budget. So basically, if everybody in this room and everybody in rooms like this all across America and clinics decided to take a 6% salary cut, and we did 6% fewer procedures and bought 6% fewer MRIs and Da Vinci machines, and we could cut child poverty in half of the United States by ourselves. I don't know whether you guys think that's worth it or not, but I think it's interesting. So the UK's war on child poverty is textbook. Remember we talked in the beginning about productive systems, about investments. And we said you need investments in children, you need investments in their parents and caregivers, you needed investments in all working age adults. What did they do? They invested in children, they invested in parents, they invested in working age adults. It was actually really interesting. And the result was this. They wanted to cut child poverty in half in the UK by within 10 years, and they did it in 5. Now, they're having a fair amount of trouble right now trying to maintain this. You know, the last few years have been tough on the UK, and a lot of political changes happened, and it's very likely that some of these gains are going to go away. But what they did was a pretty remarkable achievement. So what can we do? I mean, I basically talked about how like major policies and major policy shifts and programs and benefits and these things are important, they work. What can we do? First, we just have to accept poor patients in every pediatric practice. It is hard to defensively call ourselves pediatricians unless we're doing this. And the truth is that we don't, a lot of us. And we can redesign our practices. Okay? I think one of the coolest articles I think in the issue is this one, which came out of the work of one of the task force subcommittees. The idea of identifying social determinants of health. So first, we need to figure out who these people are who need these kinds of social support, social system support. And the thing about it is that it's actually not that difficult. There are plenty of instruments out there. WeCare, SWIC, MASK, iHelp. With iHelp, Jeffrey Colvin, who's a researcher in Kansas City that I'm working with, we found that teaching iHelp to residents dramatically increased the number of social service need detections and social service referrals and services received, and was quite accurate. Okay, but it's not the only tool out there. There are other tools, health leads, even the Bright Futures intake form. Once we find these kids, we have to link them to community-based services. Berrigan Nelson is involved right now in work with the 211 LA system. Do people know what 211 is? How many people know? Okay, good. 211 is it's run county by county, but it's a nationwide, essentially social needs hotline. Okay, that amazingly covers about almost 95% of the U.S. population. Okay, and what Berrigan has done is designed a randomized controlled trial to actually use 211 to provide the linkages, to provide developmental screening, referral, and care coordination and follow-up through the 211 telephone system to link families in need with community-based developmental services. And it's still early, but the preliminary results are kind of staggering, I have to say. If this turns out to be real, then Berrigan will have developed, along with 211, an intervention that probably justifiably would completely change how we do developmental screening in this country. We can embed programs within practices. Tons of programs exist that you've heard about. Reach Out and Read, Healthy Steps, Medical Legal Partnerships, Health Leads. Tamani Coker, her parent trial, which redesigns practices in ways that are aimed at improving anticipatory guidance, health education, and detecting social needs. Medical financial partnerships, Adam again, and Tamani are working to actually build, sort of co-locate and build financial services for low-income patients attached to or somehow connected with clinics. This includes things like matched savings programs to actually get at the asset building aspect of it and not just income. And in partnership with banks, I mean, this is doable. And then partnerships with home visitation programs. These are things that practices can and should consider. That all of our, and I look at this and I think I'm such a crappy division chief because we don't do any of this stuff. You know, we test it out and we do stuff in other clinics and for other people's patients, and we have not yet done it for ourselves. And I'm so ashamed. But you know, we're going to be undertaking next year a large strategic planning retreat and process, and I think, you know, Shahram's going to lead us to the promised land. So, what should individual pediatricians learn? Okay, so what can we do, but also what can we learn? Because learning and teaching and raising up medical students and residents to know what to do and how to do it is important. And another task force subcommittee is in charge of developing a curriculum. Adam's actually on this committee as well. The idea of and they've identified essentially 4 main curricular elements that and are in the process of developing modules and web-based tools and all kinds of things that can be accessed by everybody. And that is ultimately the goal. And I think I'm just really impressed by the amount of work that this committee has been putting in and the results that they're going to come up with. And I think this will be really useful when it comes time. And finally, sort of what can child healthcare systems do? And we can do a lot. The 2 examples that are really talked about in one of the articles are Nationwide Children's Hospital, that's in Columbus, Nationwide Children's Hospital's Healthy Neighborhoods, Healthy Families Initiative. And they decided to tackle housing. It's a children's hospital, and they decided to tackle housing. And they set up partnerships with community development organizations, banks, and state agencies, and they're in the process of investing $16 million in revitalizing 3 zip codes around the hospital. Now, 16 million sounds like a lot. It is a lot, but actually, remember, how much did Ronald Reagan cost to build this beautiful building? It was like $1 billion, right? We spent $1 billion to build this hospital. So 16 million, you know, this is within the realm of reason. Boston Medical Center's Vital Village Network is a partnership, a very ambitious partnership, actually quite similar to, in many respects, to Neil Halfon's EDSI project, which was a partnership with 75 community organizations in 3 depressed neighborhoods, basically trying to come up with what they think will be a pretty novel way of sharing data and being able to work with each other in that way and to microfinance these community identified projects, which is also interesting. And even, this wasn't in the article, but Neil's CHISTI project, Child Health System Transformation Initiative, is really looking for ambitious ways to do this on a bigger scale. I mean, just in communities all around the country. And he's making enormous amounts of progress. I'm really excited to see where that's going to go, because I think it's going to go far. So in the end, we are not helpless. We're not. You know, things are not as dark as it might appear. But there is so much that needs to be done, so much. And there's so much that we can do. And so really the question for everybody, as you're walking out, if you have any questions at all, is what will you do? And I hope you guys ask that. Thank you.